So Cardiac Dimensions was founded 19 years ago. Its primary purpose was to help impact patients suffering from functional mitral regurgitation with a less invasive procedure. The Carillon mitral contour system was born.
The Carillon device, or Carillon device, is a coronary sinus-based cinching device that's implanted via the internal jugular vein into the coronary sinus like a CRT lead. A distal anchor is placed in the distal part of the vein. It's opened and locked, and then tension is pulled simply by pulling up on the delivery catheter. And then a proximal anchor is placed in the proximal part of the coronary vein. And it provides a cinching force on the posterior aspect of the mitral annulus.
Well, it fits actually earlier than all other techniques because it's less invasive, so we can treat and will treat patients who have less severe MR, and we do this in order to interrupt the vicious circle, which is between FMR and dilation of the left ventricle. Well, Carillon is a minimal invasive technique to repair mitral valves by an indirect annuloplasty, which reduces the severity of mitral valve regurgitation.
So in the United States, we are going to do the pivotal trial for the Carillon device to say that if you are going to have medical treatment versus Carillon trial, Carillon device, are you going to do better in terms of death, heart failure admission, or your functional capacity? So this is first of the kind trial because we are going to treat patients who have 2 to 4+ mitral regurgitation. All our previous trials were related to 3 or 4+ mitral regurgitation. So we are going to treat 2+ mitral regurgitation, and then we are going to have sequential treatment. Whatever other treatments they need after 6 months, we will do that. So this will allow us to do 2 treatments at the same time. What we'll expect to learn from it is to say that what is the right way to treat the patients with mitral regurgitation and heart failure. And the second question is treating early, meaning 2+ mitral regurgitation, is it going to make a difference long term? So both these questions are not answered as of now. So this is the first time that we are going to answer the question. Very importantly, we are also going to try a new trial design. So it's a double-blind, sham-controlled trial. So whether we can do this kind of a trial in the United States, this is in a large population with multiple centers, is another scientific important question that we are going to see.
The REDUCE-FMR study was unusual, unique. Not only was it the first ever randomized, double-blind, sham-controlled trial in this field, but it also included a subpopulation of patients with moderate mitral regurgitation. Prior to this, we had information from COAPT and MITRA-FR around people with quite marked mitral regurgitation. But REDUCE-FMR included people with less severe mitral regurgitation. Despite this, we showed improvements in mitral regurgitation and left ventricular dimensions. And so what we now have is an evolving situation which many physicians will think is logical, that if you have a procedure that is low risk, that is relatively quick, and that is acceptable to patients, you may want to treat patients with moderate mitral regurgitation before they get severe mitral regurgitation and all of the adverse remodeling and the disadvantages that that brings to the syndrome of heart failure.
We know that functional MR in heart failure is a devastating disease, reaching for mortality rates at 1 year between 10 to 20%, having mortality rates of about 50% or higher at 5 years' time. So we know that these are dependent on the amount of functional regurgitation, regurgitant volume, but also on the dimensions of the ventricle. So inducing a positive remodeling, instead looking at the ongoing negative remodeling of the natural course of the disease, I think is a very important interception into the disease process and should be initiated earlier than currently been done.